right, I'll start out and then you can ask away. Today we wanted to, actually part of the reason I did a PowerPoint is we've been working on this for more than 2 years, to know all the way back to December of 2010 after I was elected, before I was sworn in, meeting with Secretary Sebelius. I've done that a number of times, both personally and through the NGA. We've reached out through our Department of Health Services Secretary and staff. We've done the same through our insurance commissioner, really because this is a very important decision for us. And what you can see is through the options we looked at, we concluded that it wasn't just a black or white answer, that there was a way that we could reduce the number of people in the state who are uninsured, and yet at the same time reduce the number of non-elderly adults who are on Medicaid. And I think that's critically important because we can reduce the number by 224,580 when it comes to people who are currently uninsured, reducing that number, but still do so in a way that allows us to determine our own destiny. We're not reliant on the federal government and where the federal government's budget is in terms of whether or not our plans will work or not work in the future. Just as the same way when it comes to entitlement reform, not only for Medicaid, but for food share, food stamp program, and for unemployment, we're trying to put in place reforms that empower individuals to control their own destiny instead of, in many cases, being permanently or long-term dependents on the government. So this is good reform. It reduces the number of people who are uninsured in this state. At the same time, it reduces the number of people who are on government assistance, increases the number of people who will be covered under the private sector and under the exchanges. And for those who were supporters of the Affordable Care Act and the exchanges, I don't see why they'd be complaining, because they told us all along it was a good thing, a good place to be at. So we think this is a good effort for us going forward. It's part of overall reform, where our goal is to get more people out into the workplace, more people covered when it comes to health care and other things in terms of the private sector, and fewer people dependent on the government, not because we've kicked them out, but because we've empowered them to take control of their own destiny, and hopefully because we've done a good job along the way to help the people of the state create more jobs.
Governor, can you describe which people would go into the exchanges and which new people would come into Medicaid?
Yeah, and Dennis Smith I know is going to do a follow-up with some more charts on that, but really what it boils down to is people who are under the federal definition of poverty will be covered, continue to be covered under Medicaid. For those above the federal poverty line, all the way up to 138% under the Affordable Care Act, they're eligible for the benefits that provide for reducing the cost of health care. It's why the example I gave of someone just over the poverty line would be in the exchange paying a premium of roughly $19 a month. So it's a good example, and you're going to hear some detractors claim that moving people into the private market or to the exchanges isn't affordable. I think most people would find it hard to imagine that with the tax subsidies that $19 a month is somehow not affordable. I think it is.
Can you
follow up on that?
People above 100%, would that include children or just adults?
Right. This is just that category of childless adults from 19 to 64. So the other criteria in terms of seniors, children, people with developmental and physical disabilities, those are, what's that? Parents are all treated differently. What I'm talking about specifically are childless adults from 19 to 64, and that's our biggest package. Now there's variations on each of those, and again, Dennis can give you some particulars on that, but again, our focus here, and that's where much of the debate and discussion has been on childless adults, and we provide a way to provide them coverage without driving into Medicaid, which is also good for healthcare providers, because one of the concerns they've had in the past is looking at reimbursement, but having more people in the private market, having more people in the exchanges where they get a better return than they do under Medicaid is actually, I think, ultimately will be good for our healthcare providers as well.
Now, you talk about wanting people to not be dependent on the government, but the way that you're sort of modeling this, doesn't this just move people from being dependent on the state government to be dependent on the federal government because they're going to get a subsidy to go into the exchanges? Doesn't it keep the same amount of dependence?
Well, under the Medicaid version, under the expansion, they'd still be, at least for the first 3 years, entirely dependent on the federal government, and then eventually more of the cost would go on the state. But Medicaid's different than exchanges. The exchanges, the way they've got it set up and the way they argue it would be set up, would be more like the private market. It certainly has a sliding scale in terms of incentives they get or benefits they get to keep the cost down. But as people work more, as they gain more, as their income goes up, they would be off of that, or at least a sliding scale off of that. But in the end, it's a way for us to manage our costs and a way to move people off of what routinely has been a heavily driven government subsidy, which is Medicaid.
Given the reliance of this plan to put people on the exchanges, is that your way of saying that you believe the Affordable Care Act is going to work?
I don't know if it's going to work or not. It's the law. And for us, I mean, I certainly, I've argued why I think it's a bad idea and why I think there are better alternatives, but it is what it is. And certainly, we're going to do what we need to do to make sure that things are set up reasonably. But that's yet another reason why we thought it was preferable for the federal government, who ultimately has authority over this, to set up the exchanges themselves. I hope it would be.
If the federal government doesn't have an exchange in Wisconsin in 2014, what happens?
Our setup on this, our timing would be connected to the exchanges being up and being operational. So we wouldn't make that transfer unless there was that alternative.
We have time for one more question. You mentioned getting people off the dependence of the government. Just the other day, you laid out $100 million for businesses to get on government dependence. Can you talk about the difference in philosophy there?
The $100 million in terms of the workforce program, $96 million, is actually the $100 million we talked about were a series of programs in terms of job training, assistance, technical colleges, assistance in putting people into placements. Those are all things that have a short-term impact. They're not permanent long-term subsidies. They're things that put people into work, give people the job skills they need to work, and then go on from there.
A number of hospital groups and healthcare advocacy groups had lobbied you to do the full Medicaid expansion. What do you say to them about your decision
I met with
today?
them. I met with them, talked about it. I mean, it's one of those where, again, we've talked about this for some time. I think people will see whether someone agrees or disagrees with their final outcome. We exhausted every option. We looked under every stone. We met with multiple groups. Just recently, I met with the leadership of the Wisconsin Hospital Association is a good example. And I think part of the reason why I don't want to put words in their mouth, but initially one of the reasons they had concerns was their concern about the exchanges and whether or not they'll work. But as was mentioned, if the exchange aren't up and operational, our switch on this is conditional on having a viable alternative. And so we think it will work. We think actually if they look at our options, we could have gone the other way under the Supreme Court decision. We could have literally saved $150 million or more in terms of just going opposite of that and not pushing to take more people off of being uninsured. But we didn't think that was a viable option either, and that would have put an incredible undue burden on our healthcare providers, which would have been passed on. In this case, I think in the end, when they look at this, and assuming things work out at the federal level, they're going to be pleased with what we ultimately put in place.
All right, thanks guys. We got to go. Thanks. We have
Thanks. Well, that one?